Hello. Today, hang on, holy cow, how'd I get to the bottom? Ah! Hold on. Oh, way to the top. Get her up there. Hello. My name's Brandon. I've made 3 videos so far for health assessment. This is going to be the 4th video of 31, I think. It's a lot of videos. I got like 30-ish days. But we got a little bit ahead. I'm going to try to do another one tonight. This chapter is going to be about the female genitourinary system. Chapter 27. Pages are 729 to... oh my gosh, a long boy. 766. Kind of long. So I'm just going to go through some of the things that I think are important and might be on the test, and so I can listen to. You're not going to be seeing much. Mainly listening. I'll ask questions, and what I expect from these questions are at the end is I'll give you time to think about them, and once you think about them, I want you to pause after I give you the correct answer and just reflect on why it's correct and just think about it. Alright, so let's start here. So we're reading. It starts off talking about like the the anatomy and physiology. Some things that I thought were important were in the internal genitalia. There are these things called rugae, and they're basically thick transverse folds that allow the vagina to dilate widely during childbirth. So that was pretty cool. There's also a new word that I learned today. It's called nulliparous female. Like, oh, what is that? Apparently, a nulliparous female is a female who has not had a baby yet. If they had a baby, it'd be a multiparous female. So what the cervix looks like in a nulliparous female is it's like a soft donut shape with a small circular hole, which is called an os. O-S. Also, I didn't really know what the uterus looked like. So what it looks like is basically pear-shaped, and it's freely movable. It's pretty cool. I then got on to reading about infant and adolescents, the developmental competence. Something was important. I wanted to learn about like how the infant's thing was working, like related to the female genitourinary tract. So it's like at birth, external genitalia are engorged, and I was like, well, why are they engorged? Well, that's because of maternal estrogen. That's what causes it. It's pretty cool. So basically, at birth, external genitalia engorged because of maternal estrogen. I then wanted to know some of the signs of puberty in females. It's pretty obvious, but some of the signs are breast development and pubic hair development. This usually happens 8 to 10 years of age. Going on, I also read about the sexual maturity rating in girls. There are 5 stages. So first stage is like pre-adolescent. There's like no hair. If there is like some fine vellus hair, like just like on the abdomen. Second stage grows a little bit over the abdomen. Third stage, it grows and spreads to the mons pubis. Fourth stage, it spreads. It's an adult type now, but it's not on the thighs. And fifth stage, not on the thighs. So no hair to labia. To hair on the labia, to hair on the spreading to mons pubis, to hair spreading everywhere would be except for on the thighs, and now it's on the thighs. So that's the 5 stages. Too bad. I was also reading about like lesbians, and it talked about how even though they may not have sex with men, they still need to have screenings for cervical cancer. Basically, it's important because even though you not have sex with men, cervical cancer is caused by HPV, and they might not also have been lesbians all their life. Maybe they might have had sex with men early on in their life. You never know. I was also reading about the aging women, and apparently estrogen plays a big role in menopause. So basically, like when estrogen decreases after menopause, it affects the women the most. There's a lot of things that happen. So here's what happens. Uterus shrinks in size because of decreased myometrium. The ovaries atrophy to 1 to 2 centimeters and are not palpable after menopause. Ovulation still may occur sporadically after menopause. Ovulation still may occur sporadic, I said it again, sacral ligaments relax and the pelvic musculature weakens. Thus, the uterus droops, the cervix shrinks and looks paler with a thick, glistening epithelium. Vagina becomes shorter, narrower, and less elastic, and without sexual activity, the vagina atrophies to one half its former length and width. Vagina epithelium atrophies, becoming thinner, drier, and itchier. This results in vaginitis. Decreased vaginal secretions leave the vagina dry and at risk for irritation and pain with intercourse. Vagina pH becomes more alkaline and glycogen content decreases from the decreased estrogen. These factors also increase the risk for vaginitis because they create a suitable medium for pathogens. The one positive is, even though all this is happening, physical changes need not affect sexual pleasure and function. You can still do it as long as you are capable of sexual exploration and you have a good partner in good health. Pretty cool. Going on, a word that I recognized earlier, amenorrhea, is absent menses. Usually happens when you're pregnant. Alright. Menopause, I think. I was also reading about characteristics of normal vagina discharge. Apparently it's small, clear, or cloudy, and it's always non-irritating. Going on, there are certain types of questions to ask adolescents about sexual behavior. Some of these are going to be like direct questions, but not being judgmental. You can ask permission statements like often girls your age and like ... Or you can do like open-ended questions like when did you ... You know, sometimes those. Pretty easy. Okay. So, let's get on to vaginal examination. What's the position that you think they would be in? It's going to be the Lithotomy position. So with this Lithotomy position, it makes them kind of feel helpless and like uncomfortable, even though they know this is a normal part of healthy living because they have to get it done. But there's some ways we can make them more comfortable during the exam. We can have her empty the bladder for examination, position the examination table so her perineum is not exposed to the inadvertent open door. Ask if she would like a friend, family member, or chaperone to be present. Position this person by the woman's head to maintain privacy. Elevate her head and shoulders to a semi-setting position to maintain eye contact. Place the stirrups so the legs are not abducted too far. Explain each step in the examination before you do it. Assure the woman she can say stop at any point she feels any discomfort. Use a gentle form touch and gradual movements make sense. Communicate through examination. Maintain a dialogue to share information. And the biggest one is using like the mirror pelvic examination. So going on to that, what is that? Mirror pelvic examination. You're doing examination, but you're giving the patient a mirror, and you can basically use it as a teaching because it can show them like when abnormalities arise. You can give them rationales for why it's coming up, and just kind of teach them some stuff. Kind of cool. I also learned about what's considered delayed puberty. If they have no pubic hair or breast development after age 13 years, that's considered delayed puberty. Also, when inspecting the labia majora, do you think there should be any bumps? You might say no, but actually there can be. There can be things called sebaceous cysts, and they are just yellowish, 1 centimeter nodules that are firm, non-tender, and there's usually multiple of them. Pretty neat. So, like I said, there's a nulliparous and multiparous females. Nulliparous, hang on here. The nulliparous perineum, it feels thick, smooth, and muscular because nothing's really going on. You haven't had a baby come out, but with a multiparous, it's thin and rigid. Makes sense. Also, we're reading about vaginal examination, doing speculum examination. Why do you think we apply pressure downward during a vaginal examination? Well, it's because we want to take pressure away from the sensitive urethra as above. Okay, tell me, what do you think the cervix normally looks like? What does it normally look like? And what does it look like during the 2nd month of pregnancy and after menopause? So, it looks pink and even normally. During the second month of pregnancy, it's blue, so that's not like a Chadwick sign, and after menopause, it's pale. What do you think the odds looks like in a nulliparous and multiparous woman? In a nulliparous woman, it's small and round, makes sense. But in a parous woman, it's a horizontal, irregular slit, and also may show healed lacerations on the side. So, learning about some variations of the cervix. There are different types. You got two variations. You got nulliparous and parous, which is like after childbirth. You can also have some lacerations like unilateral transverse. So it's like to the right. Bilateral transverse is a line all the way to the middle. Skeletal is like a crackling, like cracks. Cervical eversion, kind of like erosion and stuff. And the Boethian cysts. The Boethian cysts, they are benign growth that commonly appear on the cervix after childbirth. Small, smooth, yellow nodules, and that may be single or multiple. Pretty neat. Cool. Let's talk about cervical tests. So, Pap test, we screen this for cervical cancer. We use it for cervical cancer, okay? We do not want to do a Pap screen if the woman is mincing or if they have heavy infectious discharge present. If you're going to do it, instruct the woman not to douche, have intercourse, or put anything into the vagina within 24 hours before collecting the semen. So there are 3 different locations you can do it. So let's talk about the first thing we can do. Do the vaginal pool. So you're gonna take the cider brush and you're gonna rub it over. You're gonna take the cider brush and rub it over the vaginal wall under the lateral of the cervix. And you're going to dip it into liquid and ta-da. Then you have the cervical scrape. You can use the cider brush or the bifid end of the air spatulum in the vagina. The more pointed blunt of the cervical os. Rotate it 360 to 70 degrees with firm pressure. Round cervix fits snugly into the spatula's groove. Scrape the surface of the SCJ and cervix with a turn instrument. Dip this in the liquid vial or spread the specimen on both sides and you're good to go. And in the cervical, you use the cervical brush. You're going to use actual cider brush, put it into the os. 360, 720 degrees, going to the right, coming out, you're going to scrape at 720. Pretty easy. I don't even know if we need to know these, but you never know. You never know. Let's talk about inspecting the vaginal wall. As you come out, you're going to open the speculum. You're going to loosen the thumb screw, but hold the speculum blades open. Slowly withdraw, looking at it. Should look pink, deeply rugated, moist, and smooth, free of any inflammation or lesions. The main thing I knew was that discharge is thin, clear, and opaque, and the biggest thing is it's odorless, which is pretty neat. Let's talk about bimanual examination of the cervix. So basically, when you're looking at it, the consistency should feel smooth and firm. As the consistency of the tip of the nose. It feels like the tip of the nose. It softens and feels velvety at 5 to 6 weeks of pregnancy. It's called the Goodell sign. And contour is evenly rounded. Mobility with the finger on either side. Move the cervix gently from side to side. Normally, this produces no pain. It's pretty cool. Let's talk about bimanual examination of the uterus. You're going to take your intravaginal fingers and intraforehead assess uterus. You're trying to determine the version of the uterus. That's what we're doing. There's 5 different versions. There's 3 different versions. You got the anteverted, you got the retroverted, and you got the mid position. Anteverted is to the right, mid position is in the middle, retroverted to the left, anteflex is to the right and flex, retroflex is to the left and flex. Pretty cool. Let's talk about the bimanual examination of adnexa. It's pretty cool. The main thing here is usually you cannot palpate the adnexa. So if you're confused on it, you might be like, oh, adnexa, but usually you can't palpate it. So it's don't mistake an abnormality for a normal structure. We'll talk about the intravaginal exam. We do this, or rectovaginal exam, sorry. We're assessing the rectovaginal spectrum, the posterior uterine wall, cul-de-sac, and rectum. Basically, you're going to note the rectovaginal spectrum should feel smooth, thin, firm, and pliable. The rectovaginal pad, which are cul-de-sac, is a potential space and usually not palpated, and the uterine wall and fundus feel firm and smooth. Cool. Another thing I want to read about is when we're preparing infants, you're going to place them on the exam table. Toddler, preschooler on parent's lap. School-age children, you're going to be on the exam table. Frog legs, no drapes. You heard? Cool. Cool. Going on. You're going to use the Pedersen speculum because it's more narrow in aging adults. Menopause and the resulting decrease in estrogen causes numerous physical changes. Pubic hair gradually decreases, becoming thin and sparse in later years. The skin is thin and fat deposits decrease, leaving the mons pubis smaller. Hanging appearance, clitoris size also decreases after age 60 years. Let's go on to the fun stuff. So we're going to start with external genitalia abnormalities. Got pediculus pubis, which is a crab lice. So they'll come in complaining of severe perineal itching. So they'll come itching with itching, and you'll observe it, and you'll be like, all right, there's some like red areas, be kind of dark spots like lice or eggs or anything. Usually it's in one spot, but can it get to the eyebrows and eyelashes? Usually this happens because of sexual contact through like clothing or bedding. On to the next one, we'll look at herpes simplex virus type 2. They'll come in and be like, oh, I got some local pain, fever, headache, or they may not have pain at all. But when you look at it, it's like clusters of small, shallow vesicles with redness. So like a bunch of cluster vesicles with redness. And it can usually erupt on genital areas and inner thigh, and so on both sides usually. Progresses, so it's like short-lived vesicles 1 to 3 days to painful ulcer crust, which is 2 to 3 weeks. And this virus can remain dormant, which is kind of neat. Going on to the next one, you got syphilic canker. No really like symptoms will come in, but you just observe that it's kind of like a small papule, and it erodes into like a red oval ulcer, and it has some yellow discharge. When you feel it, it's kind of non-tender, and you can lift it up like a button between your fingers. Could be unnoticed, but usually secondary syphilitis follows with this. Now let's talk about red rash or contact dermatitis. Basically, they'll come in about, I have a history. Basically, they had contact down there with the allergic substance in the environment, which causes really bad itching. So then you'll look at it and you'll see a primary lesions like red swollen vesicle, weeping of lesions, and crust and stuff. That all occurs from like excess scratching or something. This can be caused by like hygiene spray or synthetic clothing. You just never know. Some more external genitalia abnormalities. HPV genital warts. They'll come in and be like, oh, I got some painful warty growth. However, they may not notice them. It'll be pink. So like pink and moist papules. Can be single or multiple in a cauliflower-like patch. HPV is the most common STI, and some of these risk factors occur caused by like early menarche and multiple sexual partners. Going on, I talk about the abscess of the Bartholin gland. They'll come in, but I have local pain, and it can be severe sometimes. You're going to look at it, and you'll be very red and inflamed. The labia is swollen, and they become like very matte. It can be like a mass and tenderness. It's kind of neat. Going on, talk about urethritis and UTI. They'll come in and be like, oh, I got inflamed urethra. And UTI can have some frequency and some like flank or suprapubic pain. And if it's an older adult, they'll have some like thinking problems, like confusion or lethargy or communicating. And when we go to look at it, there's definitely going to be pain and redness along the urethra, maybe some discharge. E. coli causes this mostly. And yeah, going on, let's talk about the urethral caruncle. You come in and be like, it's very tender. Have some pain with urination, frequency, bloody urine, and there may not be symptoms at all. When you look at it, it'd be like a small, benign mass, like a red mass, and it's protruding from the meatus, usually secondary urethritis or skinitis. Pretty kind of neat, I think. Okay, let's look at something new. Pelvic musculature abnormalities. Cytocell. Basically, you got pressure in the vagina and stress incontinence. That's what they'll come in complaining about. Pressure in the vagina, stress incontinence. You look at it when they strain, you're going to see widening, and you're going to see a round interior bulge. Basically, the bladder prolapses into the vagina. Going on to the rectocell, again, vaginal pressure, and it might be constipation. And when they strain, you'll notice widening, and you'll notice a bulge from the posterior part. So the rectum prolapses into the vagina here. Now let's look at uterine prolapse. You look at it, it basically be straining or standing. The uterus protrudes into the vagina. Usually non-tender, and you could have a broad-based gait. There's 3 grades. First is a cervix appears at introitus with straining. 2nd degree, cervix appears at introitus. Cervix bulges outside introitus with straining. And 3rd degree, cervix is enlarged. Edematous protrudes markedly and without straining. Now let's look at some cervix abnormalities. Look at the bluish cervix cyanosis. Whenever you see this, it's usually caused by pregnancy. It's like the Chadwick sign at 6 to 8 week gestation. And it's like hypoxia or venous conditions, like heart failure and pelvic tumor. Talk about the erosion. The cervical lips look inflamed and eroded. There can be some inflammation, but there is no loss of tissues usually. Let's look about HPV. Various forms, warty growth. No, skip it. Talk about cervical polyp. It'll come in complaining of discharge or bleeding. Look at it. It's red, and the growth is coming from the os. It's benign, but you have to determine that from biopsy. Now let's learn about the diastibistal, the death syndrome. I'm just going to read it to you. Says prenatal exposure to death causes rare tumor and cervical and vaginal abnormalities not present until adolescence. Death was given to some pregnant women from 1940 to 1970. Red granular patches of columnar epithelium extend beyond normal squamous-columnar junction into cervical and into fornices. Cervical abnormalities like circular groove, transverse ridge, protuberant anterior lip, coxcomb formation, the death exposure, cause infertility, pregnancy, spontaneous abortion, and preterm labor. There's a lot of stuff. Let's learn about cervical cancer. Cool. Cervical cancer is basically the kind bleeding, menstrual periods, after sex, or menopause. Some discharge. You're gonna look at it, be like an ulcer and duration are usually signs, and usually you diagnose this with Pap test. Cool. Let's learn about some vulval vaginal inflammations like atrophic vaginitis. Come in. Someone after postmenopause will have some itching, some burning, and maybe some discharge with blood. However, these symptoms are gradually because of the slow thinning of the epithelial layers. You're going to look at it, it'll be pale, and the areas bleed easily. Vagina may be shortened and narrowed, and estrogen causes it to do this, really. Learning about the vulvovaginal candidiasis. That's what we're focusing on, candidiasis. They'll come in, they have itching and white discharge. You look at it, the vulva and vagina are red and swollen. And the discharge is cottage cheese-like. That's how you're going to know the candidiasis. And some of these causes could be like antibiotics, oral contraceptives, diabetes, douching, normal flora balance, stuff like that. Let's learn about vulvovaginal trichomoniasis. Look at it. It'll tell you, be like, oh, this is itchy, and I have some water discharge, frequency, and stuff like that. You're going to look at it. Vulva is very red. It has the P-to-G, and basically it's what's up. Let's learn about bacterial vaginosis. They'll come in and be like, I'm constantly wet down there and it smells fishy. You look at it, you have some white grayish discharge, and there's no inflammation because this is parasitic. However, when you look at the microscope, there'll be clue cells basically, and it's kind of cool. Now let's learn about chlamydia. They're going to come in. They may have symptoms. If they do, they'll have urinary frequency, dysuria, vaginal discharge, or postcoital bleeding. You're going to look down there and be like yellow, or there may be yellow-green discharge, but these could be snaking for gonorrhea. This needs to be treated because you could get pelvic inflammatory disease or infertility. Looking at gonorrhea, you could have like vaginal discharge, uterine bleeding, stuff like that. Looking down, there's usually no signs, but there may be a purulent vaginal discharge, and you diagnose it by culturing. Alright, we're on the last stretch. Before we ask some questions, our review right here. I don't know if we need to ask those questions or not. Let's talk about pregnancy. Menorrhea, we know that's trying to pregnancy, got fatigue, breast enlargement, nausea, change in food tolerance, and weight gain. Early signs like diagnosis of vaginal mucosa and cervix, like Chadwick's sign, palpation, soft consistency of cervix, enlarging uterus with compression, fundus, and isthmus. Cool. Learning about myomas, we're going to come in. It depends on the size and location. They may have some discomfort, some heaviness, some pressure, urinary frequency. You just never know. Looking at it, uterus is enlarged. It's very movable, and it's usually painless nodules, and heavy bleeding causes anemia. You gotta use ultrasound to confirm this, though, brother. Looking at carcinoma of the endometrium. It's abnormal and normal bleeding before menopause or post-menopause bleeding. Pain and weight loss occur, and with this, uterus may be enlarged. Look about endometriosis and have some cyclic or chronic pelvic pain. Maybe some low backache, and you may have some bleeding, or there may not be symptoms at all going on. Uterus does not move, and it's very tender to movement. It's kind of neat. And some other masses are tender to palpation too. Cool. Going on, let's learn about acute salpingitis. With this, they're going to come in and be like, I got a sudden fever, super pubic pain, and tenderness. Alrighty. If it's acute, moving the cervix and uterus causes very intense pain, and there's a purulent discharge from the cervix. And if it's chronic, it's bilateral, tender, and fixed adnexal masses. Lastly, let's look at the ectopic pregnancy. Basically, sharp pain they'll come in with, and maybe some new bleeding. You'll look down there, be like a softening of the cervix or fundus. Cervix and uterus movement causes pain. It's not good. And if there's a rupture, there may be decreased BP, tachycardia, diaphoresis, shock, and you gotta treat that as an emergency. Well, I was gonna ask questions, but I don't think I'm going to. I'm gonna maybe change up the format because this is a long one. But yeah, hopefully that helped. I got 27 freaking more of these and other classes to do too. Peace.